Hello guys, and welcome to this new video in a pathology playlist which speaks about Crohn's disease, one of the inflammatory bowel diseases that affect the GIT tract. Let's start with the video. So as a start, what is an inflammatory bowel disease or IBD? We have two types of inflammatory bowel disease. The first one is Crohn's disease or regional enteritis. The second one is ulcerative colitis. Now, both of these diseases are common in being chronic conditions, which mean they last for long periods of time, that affect the GIT wall, in which there is inappropriate mucosal immune activation. Now, there are three major criteria to distinguish between these two diseases. However, the distinguish might be most commonly hard, and it might be even impossible in 15% of the cases, which is known as indefinite colitis. The first one is what is the pathogenesis. For Crohn's disease, it is an immune-related condition. However, in an ulcerative colitis, which we will speak about it in another video, is an autoimmunity. However, the distribution within the GIT is very different. This one affects literally any part of the GIT. In ulcerative colitis, it affects the colon or the large intestine and the rectum most commonly. Now, in the morphology and appearance of both of these diseases, the Crohn's disease is commonly transmural. However, ulcerative colitis is mucosa and submucosal involvement. First, we will look to the involvement within the GIT tract. Now, we said that it can involve literally any part of the GIT, but Crohn's disease most commonly come in the small intestine in about 40% of the cases. However, it might come with the small intestine and in the large intestine or colon involvement in 30% of the cases, and the remaining cases are actually for only large intestinal involvement. Now, yes, it can involve any part of the GIT, but we have most common places that are affected with Crohn's disease. The first one is the lower part of the ileum. Second, we have the ileocecal junction, and then we have the cecum. Now, these areas are the most parts affected, and if they are affected with other parts of the GIT, these will suffer from the severest parts of this disease. This patchy appearance and distribution of this disease have given it a very important character known as skip lesion, in which there is multiple separate, sharply distinguished areas of the GIT that are involved. This known as skip lesions, and this word is very important. Crohn's disease is actually related to aphthous ulcers or conquer lesions that appear on the mouth. However, it is not always any ulcers that appear on the mouth are related to Crohn's disease. This relation have came from the fact that the small intestine of patients with Crohn's disease have shown to have aphthous-like ulcers. Now, these may also coalesce and elongate, making tortuous ulcers along the axis of the bowel. Now, in this disease, patient will have depressions and elevations within the mucosa, and these depressions and elevations between the normal and the diseased part of the mucosa give it a very characteristic appearance known as cobblestone appearance, which look like the stones in the street. So you can look, and this is in an autopsy from a dead patient, and you can see how it looks like stones in the street. And also this picture here from an endoscope, as well as in this picture here, you can see how the cobblestoning is clearly apparent in the Crohn's disease. Now, you remember earlier that I said that these Crohn's disease involve deeper ulcerations or deeper fissures, which are known as transmural ulcerations and fissures, and these actually here may form fistula and tracts between the normal crypts of the small intestine, and you will see picture better for this one. This image here shows how there will be fistulas and tracts between the normal crypts, and there will be also abscesses in between, and this is very important in Crohn's disease. Now, in a cross section for a patient with Crohn's disease, you can see how there's edema of the mucosa as well as inflammation, and we have also submucosal fibrosis, as you can see here. there is fibrosis in the submucosal layer, and also we have hypertrophy in the muscularis propria. Now, all these factors have led to the thickening of the gut wall as compared to a normal person, and this thickening have induced the formation of strictures as seen in this barium swallow picture. As you can see, this is the normal lining of the intestine, and here we have a stricture which may result from the excessive thickening of the gut wall. Finally, you can know from the normal anatomy that we have something known as mesentery fat that surrounds parts of the GIT, especially of the small intestine. But here in Crohn disease, there will be fat wrapping or creeping fat, which is extensive wrapping and surrounding of the gut wall with the fat of the mesentery. And this is actually abnormally extended here. This image also shows how this mesenteric fat surrounds and extends around the serosal surfaces of the small intestine, and this is known as creeping fat. Going deeper, microscopic appearance of Crohn's disease shows abundancy of neutrophils, which are most commonly concentrated inside the crypts of the normal layers of the gut wall, and as a result changing these normal crypts into crypt abscesses. Now, these crypt abscesses may form fistulations inside and pus tracts between these layers, and as a result there will be distortion and abscesses all over the gut wall, and lead to the distortion of the mucosal architecture, leading to a haphazard orientation of the crypts. And this is actually seen more commonly when there is repeated destruction and regeneration of the disease. And as I mean by this is for longer periods of time. Crohn's disease is also associated with metaplasia. Now, in the small intestine, we have metaplasia that resembles the gastric glands. However, in the large intestine, we can see that there is different metaplasia. In the colon, there will be Banach cells metaplasia, which are cells that are normally only present in the small intestine, and they do not present normally in the descending part of the colon, and therefore, if they are present here, they may be characteristic for Crohn's disease. After many years with the disease, there might be also appearance of mucosal atrophy and loss of the crypts, as you can see in these images, which are normally present and they are not present in Crohn's disease. One of the most important, and actually it is the hallmark of Crohn's disease, is the appearance of granuloma. And this specific type of granuloma is non-caseating granuloma. They do not contain the cheesy appearance of the other granulomas, happening in 35% of the cases. And they are actually present in both the active disease and the uninvolved regions of the GIT. They can also appear in any layer of the GIT, and they can involve in the mesenteric lymph nodes. However, their absence is not exclusive for this disease. However, of their importance, their absence doesn't exclude the presence of Crohn's disease. Now, one of the extra-intestinal manifestations of Crohn's disease is the appearance of granulomas-like or rash-like appearance in the skin. And this one here is known as cutaneous granuloma, and they are misleadingly known as metastatic Crohn's disease. It appears with Crohn's disease, however, it is not metastatic. What I mean, it doesn't transfer from the GIT into the skin. And also there might be patient without a GIT granuloma, but it might appear in the skin. The granuloma is cutaneous granuloma. Malignancy in Crohn's disease can be seen when there is colonic involvement, and if you think of recurrence after surgery, it is most commonly present in Crohn's disease, which is distinguished from ulcerative colitis, and this might be correlated with the patchy and skip lesions appearance of this disease. One of the important points also to distinguish Crohn's disease from ulcerative colitis is the presence of fistula, especially in the anal fistula. And this is actually not seen with the disease that include most part of the rectum and the colon, which is known as ulcerative colitis. And this is quite interesting. Also, toxic megacolon, which is the excessive enlargement of the diameter of the large intestine, is not commonly seen with Crohn's disease. Guys, we've reached the end of this video. I hope you enjoyed watching it, and if you did, please share it with your friends. This is Adnan Medics, and see you in another video.